I think. Okay, well, I see the time's 7:30, so we'll make a start. And I welcome you all to 2023's first combined ANZSOM and SOM webinar, a webinar where we are learning from each other. And what we tend to do is we choose a theme and then we choose speakers from both societies so that we can share experiences. And today's theme's loosely around occupational medicine and our interaction and how we influence decision makers. Now, my name is Dominic Yong, and I'm the president of ANZSOM, the Australian New Zealand Society of Occupational Medicine. I'm an occupational physician from Melbourne. Melbourne's the southern part of Australia and Wurundjeri land, and I acknowledge the Wurundjeri people, the Kulin Nation, as the traditional owners of the land, and I extend my respects to elders past, present and emerging. Now, this webinar is a product of our model of collaboration that ANZSOM and SOM signed 2 years ago, and we have a number of ways that we do collaborate. At the end of last year, ANZSOM has put forward a new position to consolidate this relationship, and we've created a SOM liaison officer. And so you can see someone on the screen called Barry Gilbert, a long-standing ANZSOM member we've been delighted that Barry's put his hand up to do this role. Barry's well known to a lot of us in Australia. He has been a long-standing member. He's been a previous president, and he's also been to the UK and assisted SOM with their recent documents on long COVID. So hopefully well known to the audience. And we thought that it would be fitting for Barry in this role to be the chair of this SOM and ANZSOM webinar. So I'm going to hand over to Barry, who's going to chair the meeting. And Barry, if you wanted to unmute yourself, and the floor's yours.
Thank you very much, Dominic, and welcome to everybody. It's lovely to have this spirit of collaboration, which really comes on from our memorandum, which was signed in March of 2021. And particularly in this era of what I call infodemic disturbance, we're going to hear tonight, I think, two very good reasons as to why both COVID-19 is really an occupational disease, and one from which we can learn a great deal, hopefully apply a great deal to try and prevent people getting into further trouble. And we're also going to hear from Paul Nicholson, of course, and he's going to present on occupational health and wellbeing and the evidence and the opportunities. I actually I'm an occupational physician in the sense that I'm not really one. I'm a public health physician who saw that a lot of public health was occupational medicine, and I enjoyed putting my foot in both camps. And I guess that the fact that many public health physicians are now members of ICO and the like, it really is an interesting combination of skills that come together, and the pandemic has certainly helped that understanding. But I still get a lot of quizzical look from people, both within the profession and without, when I say I do occupational medicine. And they say, well, you're an occupational therapist, or what does that mean? So I think that we've got a lot of explaining to do outside of the profession. And part of this collaboration, I think, is to recognise that we have a lot of educational abilities, which eventually lead to improved health in the workplace. So you don't want to hear from me, you want to hear from the people that have come along to talk to us. And so the most important thing about these sessions are that they run on time. So we'll try and do that to the best of our ability. We will leave questions to a panel question and answer at the end. And please finish your questions, if you can, in the chat box area. And that'll be monitored, and we'll try and answer as many of those questions as we possibly can. I'd just like to say thank you, special thanks to Nick Powell for his ability to really encourage this collaboration and make it work. And also, of course, Dominic, as our president, there's a lot of enthusiasm for this joint learning initiative, and one of I think very important collaboration. So our first speaker is Catherine Kelaher, who's an occupational physician in Canberra, which is where I also come from at the present time. And she's going to speak to us about occupational medicine in the context of COVID and the contribution to the pandemic response. It has been difficult in lots of jurisdictions in Australia to get traction with the right people in government. And Catherine is one of those who has an uncanny ability to get traction within the bureaucracy. And I think she has a lot of interesting stuff to tell us. So without further ado, I'm going to ask Catherine to put up her presentation, and that'll be for 20 minutes. That'll be followed again with another 20-minute presentation by Paul Nicholson, and then the question and answer session. So over to Catherine.
Right, so I'll get off mute and I've achieved the first barrier. So thanks so much, Barry and Dominic and Nick, and hello everybody, and thank you so much for having me today. So today I'm speaking about the occupational medicine contribution to the Australian COVID-19 response. And that's from my perspective in my previous role as the Principal Medical Advisor at the Office of Health Protection in the Australian Government Department of Health and Aged Care, and that was from 2020 through to 2022. So just to set the scene, I'd like to share a little bit about how I got there, and also to describe the Australian approach to emergency response and management and our supporting structure, so you have an understanding of how it all works. So you may remember in late 2019, Australia caught fire. This is Canberra, where I'm from. If you have a look on the right, that's out from my back door across the Brindabellas. And on the left, there's a couple of photos of Parliament House. As you can see, the fires were very close and it was very smoky. And in fact, we actually had a couple of the worst days in the world for air quality in Canberra. And it was around this time that I chatted very informally to our Chief Medical Officer about the Principal Medical Advisor role at the Office of Health Protection. And after that informal chat, I then escaped the flames and the smoke and ended up here, Canada, ticking heli skiing off my husband's bucket list for his 50th birthday, and this is us. And whilst I was away, I was formally offered the role of Principal Medical Advisor at Health, and I accepted, and they quickly got back to me and asked when I could start. I said yes, 2 weeks after I give notice, thinking that was quite short and sharp, but with the news of pandemic spreading globally, they shot back with that might not be soon enough. So I arrived back in Australia on the 15th of February 2020, cleaned out my office at Defence on Monday, and started in my new role at the Office of Health Protection on the following Tuesday. So the Office of Health Protection is led by our Chief Medical Officer. Its role is to protect the health of Australians and manage and coordinate incident responses. It's got 5 sections, and these underwent very frequent rearrangement during the pandemic, as you can imagine. And it's currently undergoing planning for the Australian version of a CDC. The National Incident Room is our nerve centre for our Commonwealth Health operations, and where our response to pandemic. Sorry, is there someone there? And all our health emergencies is managed. So it activated in January 2020 for COVID, but this was actually the 4th activation in as many months. It had been activated on the 7th of November in response to a measles outbreak in Samoa, again in the response to the bushfires along the central and northern coast of New South Wales. And the 3rd activation was for the White Island volcano tragedy, you may remember, occurred in late 2019 off the coast of New Zealand. And in response to COVID, the health staff, and particularly in the Office of Health Protection, surged by more than 300%, with expertise gained from an array of fields, including emergency management, epidemiology, public health physicians, data analysts, modelers, but also included an array of others, essentially warm bodies, to help with the huge increase in the workload. And I would note that there was no fatigue or burnout management either initially or as the pandemic progressed. So in my role in the Office of Health Protection as the only occupational physician in health, I led the Medical and Scientific Advice Unit, which provides clinical input to the Directorate and the Department more broadly. And part of my role in that capacity was to attend and contribute to the Australian Health Protection Principal Committee meetings, or the AHPPC. So the AHPPC is one of our 4 principal committees that supports national cabinet and government decision making in health emergencies. And in addition to the AHPPC, there's the Health Services Principal Committee, Clinical Principal Committee, Mental Health Principal Committee, and probably similar to the UK HSA, the AHPPC is the key decision making committee for health emergencies, and it provides advice on health protection matters and national priorities. It's also tasked with the role of mitigating emerging health threats related to infectious diseases, the environment, as well as natural and human-made disasters. And it works with jurisdictions to develop and adopt aligned national protection policies, guidelines, and standards. And that's often more difficult than it sounds. So the AHPPC usually oversees 5 standing committees, 1 advisory group, and these committees provide the principal mechanism by which states, territories, and share resources, information, expertise, and decision making. And some of these committees have been absolutely integral to our COVID-19 response. For example, CDNA, the Communicable Disease Network of Australia, develops outbreak guidelines, our series of national guidelines, and delivers public health advice in an array of settings. I sat on the CDA and provided the OCMED input on that panel. The Public Health Laboratory Network of Australia provides advice about testing, supplies, emerging technologies, and variants. N-Health was engaged in the wastewater testing effort. As you know, that was an early warning system used in many countries. And the National Health Emergency Standing Committee helped stand up OSMAT teams, which are early response teams, to assist in a variety of efforts, which included repatriating Australians in the early days. If you remember a Diamond Princess, one of the cruise ships stranded in Japan, repatriating Australian citizens from China. They provided support for extreme or remote outbreaks, so in regional Australia, and also provide support for our Pacific neighbours. And we provided support in Fiji and Papua New Guinea, and also following the volcano eruption and tsunami in Tonga. So there were also several time-limited committees that were stood up in response to COVID, including ICEG, Infection Control Expert Group, which was composed of infection prevention control and infectious disease experts. And we had occupational physician expertise provided through Malcolm Sim, who attended that committee. And we also had the Aged Care Advisory Group, which was set up to provide guidance to residential aged care facilities around outbreak preparedness, prevention, response, and recovery. And they had a range of expertise: infection prevention control, ID, general practitioners, geriatricians, aged care workers, and I was able to provide, as an occupational physician, to provide that occupational medicine lens. So this is AHPPC, and this is one of the last face-to-face meetings before everybody went into lockdown, and this was in March 2020. So AHPPC is chaired by the Australian Chief Medical Officer, and Professor Brendan Murphy is chairing in this picture. That's him. And he was CMO until July 2020, when Paul Kelly, who's hiding behind him, took over. AHPPC is comprised of chief medical officers who are mainly public health physicians. It's also attended by experts, modelers, ID, and they have expert visitors who might be presenting on specific issues. Also regularly attended by the Surgeon General of the Defence Force and the representatives of the subcommittees I just discussed. So throughout the pandemic, there was an ongoing requirement for the rapid development of novel health policy, and also to frequently review and update policy as new evidence emerged and the pandemic evolved. All members of our AHPPC inform, advice, and all contribute. All state representatives have very different needs, drivers, different resources, and strongly represent their jurisdictions. So decisions are often fraught and require considerable discussion and negotiation as we balance available evidence, public health measures, social and political and other pressures. And we try to develop harmonised response and have those delivered in the jurisdictions. The pace, as you can imagine, was frenetic. From the beginning of the pandemic until July 2020, there was a 2-hour meeting every day, 7 days a week, and sometimes twice a day, sometimes all day. Meetings went to 3 times a week, but then returned to daily meetings during the Delta and Omicron waves. And from the beginning of the pandemic, there have been more than 500 meetings and in excess of 108 publications, and that's just up to the end of 2021. So where is the occupational contribution in this environment? Well, that's me in the back, looking very, very thoughtful. From my perspective, the occupational medicine contribution to the pandemic has been and is considerable. We have a really different perspective. So public health is often thought to encompass a consideration of the population as a whole, but often public health policy and interest doesn't extend into the workplaces. And this is what I discovered working in health. It's often thought that the work health and safety regulations manage risk and there's no requirement for any further input. The other thing is that they have a very limited experience in managing risk using a system-based framework. As this audience knows, occupational medicine brings a very different approach to risk assessment and management. And this group will have a really good understanding of these diagrams and the concepts of risk management used in the hierarchy of control, using the hierarchy of control to layer controls managing risk using a system-based approach. I think in health and more broadly, there's little or no understanding of these concepts. For most people in health, managing this risk was all about application of the lowest level of controls and a focus on IPC, infection prevention control, and PPE. So having an occupational medicine lens at health has ensured that policy is informed by that system-based management approach, and it has been from the earliest days of the pandemic, and workers and the workplace have been consistently considered in policy development. So just to demonstrate the differences in a system-based risk management approach to standard approaches to hazard management, I just wanted to show a real-world example that occurred early in the pandemic. So with your indulgence, I'm going to take you back to March 2020. The number of new cases in Australia had grown sharply and reached 350 cases a day. That sounds very low with our retrospectoscope, but it was high at that point. The National Cabinet in Australia had been established and the Australian government had declared a human biosecurity emergency. Australian borders were closed to all non-residents and returning residents were now required to quarantine. So we had social distancing rules introduced and state governments start to close non-essential services. And there was considerable community concern, and in supermarkets there was panic buying, toilet paper hoarding, and supermarkets had ceased online shopping. So in response, supermarkets provide an essential service. A task force was set up to develop a plan to support safe function and to minimise risk. And this was their initial proposal for mitigations to manage risks in supermarkets. That was that four dot points there. And as you can see, it really lacks a very systematic approach. It only focuses on customers, not staff. It only considers lower level administrative controls. You don't see PPE on there, and you may think that's odd given that's usually the first thing people consider, but remember at this stage of the pandemic there were significant supply issues that affected us and much of the world for some period, so PPE was only available at that stage for healthcare workers. So it was at this stage I was asked for some input, and here is my first pass, and it probably looks very similar to some of the things that others on this call may have written. It focuses on the highest level controls, and you'll remember at this stage there was also no vaccination and no testing, so there's no testing program here. And the further layered array of administrative controls at every level designed to reduce interactions and minimise exposure opportunities, and to reduce both entry to the facility and transmission within the facility. So this was well received by our supermarkets. We have three major supermarkets. We've got Aldi, Woolworths and Coles. And it was so well received that the Woolworths group had then appointed a occupational environmental physician as their CMO, as they liked the approach so much. So this is just one example of many, many other examples of occupational medicine approach informing policy. You can see here in this very early statement in March around vulnerable people in the workplace, a focus on an occupational medicine approach to risk management and incorporated into an AHPPC statement to ensure consideration of the worker, their relevant health issues and wishes, the workplace, the environment and controls, and the work. What does it involve and what are the likely exposures? This one on the 10th of April, you can see again an occupational medicine approach is applied to risk assessment and management, and the hierarchy of controls is introduced into AHPPC's guidance. And this paper, which was also developed early in the pandemic to help people with their GPs assess and consider a person's individual health risk related to COVID-19 and develop a plan to manage this with their GP. And whilst people have become much more familiar with potential controls that they can individually apply to manage the risk, this type of approach of risk management has become much more relevant as public health restrictions are rolled back and individuals need to consider how they best manage their own risk. And this guidance was also supported by a risk management plan and also guidance for general practitioners. And this type of approach, this is the support that we developed, can also theoretically be used in the workplace for supervisors and workers at risk of severe disease to determine an agreed approach to managing risk at work during different epidemiological conditions. Since publication of this tool, several risk calculators have been developed to guide risk, and you're probably familiar with one of them based on Open Safely data, and there's the Q-COVID risk calculator. However, most of these calculators will only consider worker risk related to their health condition, sometimes ethnicity and socioeconomic status, but as we mentioned, it's also important to consider aspects of the work and the workplace as these inform exposure assessment and controls. So an occupational physician is essential to help with this type of assessment. The same risk-based approach has also informed iCare guidance, and it's explicit in their document, minimising the risk of infectious respiratory disease transmission in the context of COVID-19, the hierarchy of controls. It informed CDNA guidelines for outbreaks in residential care facilities to balance the risk related to COVID with the risk related to deconditioning, social isolation, which had been associated with protracted isolation and quarantine. And it also informed guidance around return to work for healthcare workers following COVID exposures. So these principles apply equally in every work environment. Occupational medicine and occupational health advice has been pivotal in Australia's response to COVID. The list you see here is an array of different areas where I've provided occupational medicine input during the pandemic. And memorable work included developing very early mitigations for the Antarctic Division, the Australian Parliament House, for the sex industry, the Summer Olympics, the Winter Olympics, the budget, the federal election, and several by-elections. And lowlights were drama over restrictions and lift access to government buildings early in the pandemic, and also managing very precious parliamentarians and athletes associated with the Australian Open. So what's next? The transition away from mandated restrictions to business as usual is an area of concern for, individuals, workplaces, healthcare, and the community, because in this brave new world, individuals, industry, the community, including health, seem to be at a loss without public health mandates to drive risk management, and they now need to assess and manage their own risk related to COVID-19. So occupational medicine is really essential in providing this guidance to manage the ongoing risk related to COVID-19 and also other public health emergencies. And this was recognised by the World Health Organization. In 2018, they released their manual for occupational health and safety in public health emergencies, noting the importance of an occupational medicine approach and input, and also World Health Organization noting the essential role of the healthcare worker in public health emergencies. On World Patient Safety Day in 2020, they released their Charter for Healthcare Worker Safely, which recognised the importance of occupational health and safety and a risk-based approach in protecting healthcare workers. So this is essential isn't it? I mean, healthcare workers were 7 times more likely to get severe disease from COVID, and it's estimated that between 80,000 and 180,000 health and care workers died from COVID in the period between January 2020 and May 2021. And the issues around mortality and morbidity related to infection are not the only concern. Evidence suggests an increased risk of thoughts of self-harm, mental health conditions, emotional exhaustion, workplace burnout, and then there's the issue of long COVID that is continues to emerge. As you know, though, these issues aren't just confined to healthcare workers. Essential workers have also been found to be at a higher risk of severe COVID-19. And it really has been and continues to be a battle to have essential workers considered as a vulnerable population in pandemic planning. But COVID-19 has shown that to be undeniably the case, and really underscores the need for national and organisational policies and practices that protect and support workers. Sorry, I think I've just had a slide failure. I'll just slide down. There we go. Cool. So therefore, going forward, it's important that occupation will be included in planning and management of future pandemic public health policies. And I just wanted to say thanks to everybody for having me here and letting me present, and also for your efforts and sacrifices during the pandemic. Thanks, everybody.
Thank you very much, Catherine. Always stimulating talks, and it's a matter of record. The enormous amount of occupational medicine activity went on, but we want to see that continue, and we want to see it continue particularly within government. I guess that the next presentation is really building on what you've already presented to us. And so we welcome very much Paul Nicholson to talk with us, and his presentation on occupational health and wellbeing and evidence and opportunities. I don't think that anyone would disagree that unless we really stick to a really good evidence pathway, we can't present all the opportunities and make the best use of them. So I'm very pleased to be introducing Paul, who's going to give us that presentation, and then at the end we will have a group discussion, a panel question and answer. Hopefully you'll be giving some thoughts into that. Just before we get Paul starting, I'll just reinforce that the position paper that the Society of Occupational Medicine produced on long COVID and return to work and what works is still a very good basis to understanding, particularly for people in Australia, the difficulties that were seen in such large numbers in Europe and the UK. And there are terrific lessons in there for Australia, which really followed 6 to 12 months a bit further behind. But they're very important issues because our focus now is on prevention of reinfection in the workplace, so that people actually then don't actually end up with a more severe form of COVID. So Paul Nicholson, we enjoy listening to your presentation today.
Okay, thanks, Barry. Can I just check everybody can see the slides?
Yes, it's there.
Great, thank you. Okay, well, thanks again for the invitation to speak today. The principal references for this are documents with which I'm sure most people will be familiar, both the SOM and ANZSOM documents relating to value. So most of the slides won't show references, they're all within that, but some of the critical references I will cite in some slides. The scope for today is looking at the evidence in terms of quality, the limitations of evidence, and about around the hierarchical model. Lots of things annoy me, but I'll focus today on annoyances around the quality of occupational health research. And based on some of those limitations and annoyances, I've put together 7 lessons for users of evidence, and that's both organisational users and individual users, and then what I think are the key opportunities for research going forwards. Now, many of you will be familiar with the hierarchical model of evidence. And one of the problems of this is that there's far more low quality evidence than there is high quality. The width of the pyramid at the bottom showing the amount of low quality evidence, and the lowest quality of evidence, which I think many experts will acknowledge, is expert opinion. Thereafter, of course, it's the individual case report, followed by case series, either of a few cases, and particularly of new diseases or new causes of disease, and then through cross-sectional studies up to case referent or case control studies, and then getting into higher quality evidence with the longitudinal cohort studies, and of course at the top there, randomized control trials and cluster randomized trials, and at the peak, systematic reviews and meta-analyses of RCTs and CRTs. And of course, as you go up the pyramid, quality increases. As you go down the pyramid, then bias increases. Now, just to look at the effect of a cross-sectional analysis versus longitudinal, if you look at this study from 2019, it looked at the psychological motivation in particular for people to participate in workplace wellbeing programs. It was a retrospective study. More than 10,000 employees participated. As I mentioned, the intervention was a workplace wellbeing program, and it was quite a lengthy follow-up for 3 years. And at the end of the study, they found that participants had better scores for job satisfaction and intention to stay. Now, of course, many cross-sectional studies will report these positive findings, but one of the advantages of this study was that they went back to look at people's scores at the very beginning and discover that these effects disappeared when controlling for pre-intervention scores. So those who were healthy at the beginning remained healthy at the end, and there was no difference in the comparison between participants and no participants when you controlled for that. Now, the limitations of the hierarchy is that RCTs and CRTs are not suitable for all occupational health questions, and other study designs and hierarchies are essential and more appropriate to investigate matters such as etiology, pathogenesis, disease frequency, diagnosis, and prognosis. And that's not just confined to occupational health, it's the same for public health as well. In terms of the quality of primary research, unfortunately, most of it is of low quality. One of the problems is the heterogeneity of design, subjects, outcome measures, and length of follow-up. Many of the designs are flawed, and often they emit important costs, particularly indirect costs of productivity loss and presenteeism, which in some cases will be based on subjective measures. Among the worst performing studies are economic evaluations, and one review reported that only 44% of studies met more than 50% of quality criteria. Now, often it isn't feasible to draw sound conclusions, but that doesn't mean to say that authors of some of this research do go on to draw conclusions, and it's up to the reader to decide whether or not those conclusions are sound. Additional issues for workplace wellbeing studies, and again, these are particularly of low quality, and only around 1 in 4 studies meet the criteria for being high quality. There's a risk of various biases, I'll explain later, in more than 2/3 of studies. Now, interestingly, return on investment is inversely related to study quality. Model studies in particular will show positive ROI, typically in the order of 4 to 1, but they suffer from over-reliance on estimates or assumptions in order to calculate that ROI. One of the other problems is that most economic evaluations derive from the USA. Now, that's not to knock the quality of the research, but we need to remember that in the USA, employers are responsible for paying or responsible co-payments towards healthcare. And that means that those models or that data is not generalizable to countries which have state-funded healthcare. By contrast, if you look at 11 European RCTs, most workplace wellbeing programs showed a negative return on investment. So overall, the popularity and commercial interest in workplace wellbeing programs is not supported by high quality evidence, either for efficacy or effectiveness or cost effectiveness. Now, the biases I mentioned are several. First of all, attention bias, in that those subjects who know they are being observed as studies might well change their behaviour simply because they know that they're being observed. Selection bias is probably one of the most common biases in workplace wellbeing studies, because those volunteers who are highly motivated are more likely to join the programme or to participate, and of course they don't represent a broad population. There are various sources of performance bias, methodological ones, particularly non-randomisation, measurement errors, subjective measures, and short follow-up. And then there's attrition bias. Those who drop out from follow-up may have a worse prognosis, but that won't be reflected in the study. And then there's publication bias. It's rather the opposite of what you see in the newspapers in terms of good news isn't newsworthy, but bad news is newsworthy. But in journals, they're more likely to publish papers which show a positive return on ROI, rather than studies which show no effect or a negative effect. Another warning is in relation to systematic reviews, because there are many papers that call themselves systematic reviews or even meta-analyses, but if you look at the methodology, in fact, they aren't. Now, the steps involved in a systematic review, and I think normally there are fewer bullet points here, but with the aid of a synonym finder on the internet, I was able to find more that started with the letter A. But the first one is deciding the questions to include and ask. Then you ascertain the inclusion criteria for those studies. You then access the systematic literature search. And this is where, unfortunately, some authors think that's enough to call their paper a systematic review. Before getting to the point of making practice recommendations, you need to appraise the accepted papers, aggregate the evidence, and by appraising them, that's to decide which ones you include and which ones you reject. Then aggregate the evidence and grade the overall quality, and then advance practice recommendations. Now, as I say, people do need to be aware when they read a paper that calls itself a systematic review to be very wary if they simply perform a systematic literature search and then make practice recommendations without going through those quality steps in between. So without going through each and every one of these steps, whatever might be called a systematic review is no more than a low quality narrative review. Now, of the annoyances, I'm sure you're familiar with the term garbage in, garbage out. In terms of garbage in, I call identify the main ones as poor methods, the lack of controls, the use of estimates, and one that I've not mentioned earlier, and that's hidden funding. We know the issues from previous studies in relation to whooping cough vaccinations, of the critical influence that undeclared financial funding can have on the reliability of results. And very often, workplace wellbeing studies do have a conflict of interest in that they might be sponsored by those who wish to advance their commercial interests. Publication bias, I mentioned. Other ones are naive trust, and that is, again, people taking face value what they read rather than critically appraising the quality of the studies. That leads on to repeating myths. And of course, then you have spin, particularly in the newspapers, of the media picking up some point and splashing it all over the media, and right across the board in terms of whether it's on the input side or the output side, the absence very often of independent and rigorous peer review. One thing that annoys me, or another thing that annoys me, is that people don't bother to read the small print and just go for the big captions, and I'll elaborate on that later. And again, people reading what they see without any appraisal, and I hope that one thing that people will leave today is with the idea that it is up to each and every one of us to form our own judgment rather than accept anything at face value. And the last one, and I learned this phrase from public health physicians, is policy-based evidence, the use of data to support policy or profit, rather than to base practice and policy on evidence. Now, I'm not saying that this next slide is an example of that, but it does emphasize some of the issues of using data that is presented by what we would normally think to be credible sources. These are both government department studies. And it looked at the access to occupational health in 2010 and in 2014. Similar numbers of employees surveyed by telephone, and they reported how many could access or what percentage could access occupational health services. Now, in 2010, the researchers reported that 38% of the UK population or the UK workforce had access to occupational health. In 2014, somehow 51% had access. Now, if anything, in those intervening years, more occupational health practitioners have retired, so there was no better access. So why should there be this remarkable difference? One of the internal inconsistencies was that in the same study, they looked at, from memory, about 250 of that 2013 sample, and asked that sample, would you use the new government Fit to Work service? 37% said that they would not, because they could access their own occupational health service. So fine, it was a subsample, but again, it's an internal inconsistency. Of interest, though, that subsample reported a similar level of access as the earlier study. So why should there be this level of difference? And it all comes down to definitions. Sorry, I seem to have lost, oh, there we go. In 2010, the researchers did not define what occupational health meant. I think this comes to Barry's point earlier in the introduction in terms of people not understanding what occupational health is. Now, in 2014, the researchers explained to those at the end of the telephone what occupational health meant. And it was defined as occupational health provides advice and practical support about how to stay healthy in the workplace and how to manage health conditions. Well, if that's what occupational health is, I, and I'm sure many others, might feel that they wasted 4 years in higher medical training. If you go back to another report commissioned by the Health and Safety Executive in the UK, commissioned in 2002, it just shows that people never learn from history, or as Winston Churchill said, that those who don't study history are destined to repeat it, because this study looked at the impact of definitions. If occupational health wasn't identified or wasn't defined, then access was stated to be lower than using a misleading definition. And in this telephone call or survey of employers, if you looked at what they regarded occupational health to be, then employers reported that occupational health was provided by those employees with health and safety training in 40% of the occasions, employees without health and safety training in 23% of occasions, and 7% of employers thought it was okay for first aiders to deliver occupational health. So we do have a crisis in terms of trying to identify to people, including government, what occupational health actually does. Now, the lessons for evidence-based practice, based on some of those earlier points, are that we all, whether we are a society or an individual or an occupational health service, we need to be better today than we were yesterday in terms of how we use evidence. Now, the first lesson is don't trust fancy ROI data or fancy graphics. Now, this is a report which cited the Harvard study, the famous or infamous Harvard study of 2010. And it's a report that is cited very often, and it showed very specific return on investment in terms of every dollar spent, how much was saved in terms of savings in absenteeism and medical costs. And just remembering the point I made earlier, this was a US study, so it's not generalizable to any other country in the world that has a state-provided healthcare system. But again, very compelling, very fancy graphics, and likely to be believed. Now, the second lesson is read the small print, because the graphics could have been put in by a graphic designer, and the authors might have had no responsibility for the design. And what the authors said in this occasion for this report was that it is, however, not always easy to deduce what proportion of expenses and costs that increment savings can be attributed to the intervention. Now, it's important to go to check the source, because whilst this was called a meta-analysis, there was poor methodology behind it and a lack of control or appraisal for the studies. But the authors of the Harvard study did warn that there were clearly limitations in the broader generalization of these findings. Now, the fourth lesson is to take responsibility individually and organizationally to appraise reports, systematic reviews, and meta-analyses before regurgitating the findings. The problems with the Harvard study of 2010 was that they only included studies of new interventions and only included one study per intervention. There was no explanation of why they chose the study they did. So if one study looked at the one intervention rather was the effective exercise programs, why would they choose one and exclude 12 or 20 or however many it was? 13 out of the 22 included studies lacked any controls, so by definition they were low quality. As I mentioned, they didn't appraise or exclude studies for risk of bias. Selection bias is a big problem in that most of the studies included motivated volunteers. 40% of interventions included self-help, where they are pretty low cost, so they're likely to produce a positive ROI. And again, in coming to economic analyses, which is what this study was, the costs weren't known and were assumed for 7 out of the 22 included studies. And Matka and indeed others criticised the review for including studies that were several decades old. In fact, the earliest one went back to 1986, and the research had substantial methodological weaknesses. Now, the fifth lesson is to look for the latest and best evidence, and I emphasise and subsequent to the Harvard study, there were large cluster randomised trials. The Illinois study, which lasted for more than 2 years. And again, this is the USA, but on this occasion, because of the better design and the better quality of the study, it showed null effects of workplace interventions on health costs, productivity, and self-reported health. And again, it showed that participants had healthier behaviours and lower medical costs at baseline. These didn't change through the course of the 2 years. And its conclusions was that 84% of previous studies that looked at medical costs and absenteeism estimates were unreliable. Now, 2 of the 3 Harvard studies did their own cluster randomized trial and followed up people at 18 months and 3 years. They found no significant differences in healthcare spending or absenteeism. They stated that the findings may temper expectations about financial return on investment from workplace wellbeing programs, including their own previous study, and again, acknowledged that most prior studies had methodological shortcomings, and in particular, as I mentioned, selection bias. So the news caption on this occasion from the Harvard study was that workplace wellbeing programs are big business, but they might not work. Now, in spite of what I said about the previous lesson, the caveat is the latest report is not always the best. And I refer here to an OECD report that was published just 3 months ago, promoting health and well-being at work policies and practices. And these are just 2 quotes from 1 page. Again, they refer to the Harvard study 2010. So here's a report from 2022, still citing papers dated back to 1986 in the Harvard 2010 review. So the question is, why did they omit relevant high quality research post 2010? And as John Ballard has pointed out in his editorial, and that was published just this week, the OECD estimates are derived from burden of disease modelling. So again, it's a modelling study and are based on a lot of assumptions, as John said. In terms of their data regarding the ROI of sit-stand desks, the sedentary activity estimates rely on only 5 studies of sit-stand desks and 1 of treadmill desks. So, the conclusions are not particularly sound in relation to that. More so, since only 1 of the 6 studies lasted for more than 6 months, more than 3 months. And if you look at other reports, well, Cochrane states that sit-stand desks, the studies of those are of low quality and have short-term effects. So again, there's a lot of information out there that we really need to take the care to understand whether or not it is reliable and robust. The last lesson really is to check expert appraisals. And one source that was particularly useful for the occupational health value proposition was the Health Evidence website in Canada. And if you look at the top 3 studies that have been reviewed here, which related to sitting time, then you can see that there are 2 studies which are marked in orange as being of medium quality. The green icon with the scales indicates that these are economic analyses. The third one down, which is of high quality with 3 green bars, with the amber lightning icon, that means to say that that study has been highly accessed, and then just randomly picking the first low quality review to be appraised by Health Evidence, and that's relating to distancing measures and containing epidemics. You can see, I say, that it is a good site for looking at medical reviews and meta-analyses and identifying very, very quickly by the colour and the extent on the scale, the quality of each review and which ones you can rely on. So it does take away a lot of the effort from us in reading the papers to decide what is trustworthy and what is not. Moving on to the opportunities, do start, stop, and continue and improve. But in terms of start, we definitely need, and this really needs the engagement of everybody, to start to generate high quality, longer duration primary studies. I think we need to shift the focus from workplace well-being to occupational health, because there are many opportunities to look at their core activities, such as health surveillance. There are lots of things that we do, such as spirometry, to monitor people who are exposed to asthmagens. But what is the true utility of spirometry? In terms of whether it adds value over questionnaires, there are only 2 studies to demonstrate that. And I do think there's a huge opportunity for professional bodies to start to debunk fake news. There is so much, and Barry at the beginning used the term infodemics. You could apply that to occupational health as well as to communicable disease. There's just so much being published out there, and particularly with regard to workplace well-being, that I think there is an opportunity for someone to take a leadership role in advising people whether or not this is a good study or otherwise. At government department level, certainly in the UK, I think we need to stop funding more of the same studies, very often of the same interventions and by the same research centres. And we need to stop regurgitating unsound findings from low quality research. And it's all too easily done, I'm afraid. In terms of opportunities to continue to improve, I think that there is we need to continue and improve measures to drive the strategy for occupational health to survive and grow, but make sure we do it based on robust appraised evidence. And again, going back to what Barry said at the beginning about being confused with occupational therapy, I can tell you that after leading the accreditation program for the Faculty of Occupational Medicine, one of the senior civil servants in the Department of Health tried to endorse me in LinkedIn for occupational therapy. So yes, it is a real problem. We do need to, let's say, let people understand, make sure people understand what occupational health is if we want to survive and grow rather than meet an early demise. The second opportunity is to build on the successes of collaboration, and it's been discussed in terms of the benefits of today's webinar, but certainly in terms of repeating the collaboration and the use of Creative Commons licenses, public domain text, as we've seen in terms of both the SOM and ANZSOM value documents, and the use of the value proposition by the Irish faculty in advocating the value of health and island strategy subsequently. And from that, how do we involve other countries, and how do we extend that collaboration to other projects? Thank you for listening.
That's fantastic, Paul. It means that we all need to go back to university and start all over again, I think, in terms of trying to work out how we can actually assess the evidence properly. But very thought-provoking, and thank you so much for that. Now, you'll have to bear with me because the chat line has a number of entries, and I'll need to scroll through them now on a small screen that I have. But it was just interesting. One of my colleagues, Bert Boffer, here in Australia, said another example that we might share is the annual employer-funded on-site influenza vaccinations, in which many of us were involved, which went the way of the dodo after studies repeatedly showed they did not lower absenteeism, whether from influenza or not. And that sort of plays very well, I think, into your talk, Paul. We really do need to properly assess where we're going, and it's hard work, isn't it?
It is.
Yeah. The interesting thing I'd like to ask Catherine, while I'm still looking and searching at the various questions, but in the chat line there is a lot of information being provided, particularly from the Society of Occupational Medicine, so there's lots of good reading for people. But Catherine, I'd like to sort of ask a question in terms of Australia today announced that the 5th vaccine administration for Australian adults has been approved. And that with the evidence that we want to use to determine what is best in terms of our intervention strategies in the workplace to try and reduce transmission in particular, do we have any evidence, to your knowledge, that in fact vaccination is going to play a role in the reduction of transmission in the workplace?
Yeah, look, previous vaccinations, the early ones, showed very minimal impact on reducing transmission. There was some, and it reduced fairly rapidly and reduced further over time. I haven't seen the data for the bivalent Omicron vaccination, but I would probably, have to review that data, but would base my controls on the fact that probably it will not impact transmission based on the previous ones, and that similar controls are going to need to be applied. And based on the epidemiological environment, we've seen controls go up and down, and that particularly is occurring in aged care facilities in Australia at the moment, where it's one of the few environments where they're still doing regular testing, and we're still having quite a number of cases and outbreaks. And they definitely need to moderate controls with the epidemiological environment. Thanks, Barry.
Yeah, good. Paul, I have got a question from you from the floor, and this is from Graham Edwards, one of our occupational physicians here in Queensland. Is that, Paul, what are your thoughts about programs like ChatGPT?
Sorry, you'll have to explain to me what that is. We don't have
GPT, I'm sure Graham could explain much better than I, but it's been very much in the news in Australia in the last week, which is really the application of AI into the whole array of scientific work in Australia, whether in fact the degree to which artificial intelligence is going to have an impact on assessing things like the things that you discussed, which is evidence. We're going to have a lot of things coming at us. I think it just adds to this burden of the infodemic, where we're getting so much information. How are we going to have a clearinghouse that's actually going to enable us to understand what is in fact helpful and what is in fact completely misleading?
Yes, I mean, one of the things that really wasn't covered in the value proposition was, and this is because there was insufficient information yet. I mean, in terms of telehealth, e-health, all these web-based or different platforms for taking away more of the human element and outsourcing it to technology. But, I mean, there were some early reports, but not sufficient to form a body of opinion. So I think it is important that we flag up what the emerging issues are, including technology, to make sure that we stay ahead of the game and gather the evidence to make sure that it develops in the right direction, rather than gets out of control and starts to the tail starts to wag the dog.
Yeah.
Sorry, I've just seen a question before that as well, in terms of is it evidence-based or evidence-informed policy? And I think or practice, it depends how you use the words. I mean, in terms of evidence-based practice, I did remove one slide, and it was to emphasize that evidence isn't everything, because usually there are caveats with evidence-based reports that say that in practice, it's a combination of what the evidence says, what the clinician's experience is, but also you have to take into account patients' own values as well. So I say, it isn't everything, as long as it evidence informed doesn't mean to say that, sort of government or somebody says, well, we understand the evidence, but we haven't got the money. So yes, but you say evidence isn't the be and all.
Yeah. Another comment from one of our members, and thanking you for the important topic, because he was making the point that we were bombarded with low quality papers during the pandemic, many of which were published in reputable journals. The question is, do you think the original phase 3 data that gave an efficacy for Pfizer vaccine at preventing infection with COVID of 95% is one example of a low quality research? Either Paul or Catherine.
Yeah, I mean, I don't have sufficient knowledge of that paper to comment. I mean, I do know that one of the big controversies before that was around Tamiflu, and employers stockpiling that when there was insufficient evidence of effectiveness. But COVID, I would defer to Catherine, or drop you in that, whichever the right phrase is.
Thanks, Paul. Yeah, well, the evidence emerged very rapidly and very quickly. And as you said, Paul, you really do need to have a look at the source of the paper and who's funded it for a start. I think we've definitely got to a place where we understand that the vaccine is not very good at necessarily preventing infection, but it is quite good at preventing severe disease, and it is up around that, although it decreases over time. So yeah, I'm not sure which particular paper you're referring to, but I agree with all Paul's points about reviewing the data and reviewing the evidence. And I imagine there was potentially some motivation in the way that the evidence was framed, because we really did want people to get vaccinated, and we wanted to provide a weight of evidence against that anti-vax information. And it was interesting, I was telling everybody before we started that World Health Organization is looking at their international health regulations, and one of the new parts of their health regulation that manages pandemic preparedness is looking at specific policy development in that misinformation, disinformation space. And I think we all probably have seen the harm that that aspect has caused, and we all need to think about that in our policies and actions going forward. Thanks.
Good. I have one more question at the moment, and Paul or others, and so how do we assess the value of the psychometric factors, the perception of doing something as compared with doing nothing.
I had to smile when I saw that one, because I had this conversation with John Ballard just over the weekend. And so many things that employers do, I believe, is because they want to be seen to be doing something. It doesn't matter whether it works or there's ROI, and that's very difficult to counter. I think probably the worst example I can think is that of a decapitation at a factory where somebody did what they shouldn't, stood on a hopper before it tilted to doze a manufacturing line, and we all knew that, according to Cochrane and other reports, that defusing or bringing in psychologists to see people medicalize the issue and potentially made things worse. But plant managers, business leaders wanted to be seen to do something, so brought in psychologists for critical defusing. And I think this is the big issue with workplace wellbeing programs. It's much easier to tell somebody to eat 5 portions in fruit and vegetables a day rather than address a toxic culture. And the example I raised with John was certainly when I was on the BMA committee, many reports reporting the fact that several trusts in the NHS had toxic cultures, yet all that the NHS would do was fund a report about healthy food options and Zumba classes in the workplace. So yes, dealing with those psychometric factors and educating managers and leaders in terms of what they should be doing rather than what's a sticking plaster solution.
Well, look, I don't have any other questions at the present time. I might call Dominic Young to come back just for a moment to say farewell to everybody. We do want to keep these sessions running on time, and or even before time. We realise that it's now probably over 0 degrees in London, so hopefully you've warmed up as a result of this particular session, and we'll get back to our 20 to 30 degrees and see how we go. But Dominic, would you like to say a few words?
Yes, I would like to again thank our speakers. Firstly, to Kath again, thank you for your service. I mean, that was that is the premier Australian Medical Committee during the pandemic, and I hope you also were looking after your own health. It sounds like all-day meetings probably not a great way to look after your health. So thank you. And Paul, also just to give you some feedback that in Australia we've at ANZSOM we've provided a submission for Australia's upcoming CDC, the Centre for Disease Control, and we've taken some of the key themes from the Occ Health Value Proposition as part of our submission. So again, thank you for that, sharing that with us. And to the rest of the people in the audience, again, I hope you enjoyed the talk. Our next SOM ANZSOM combined webinar is the 20th of September. So please put that in your calendar. And also to let you all know that the ANZSOM annual scientific meeting will be in Canberra, Kath's home city, and it'll be in October 22nd to the 25th. So look out for that as well. But Barry, you've run a fantastic meeting and we're on time. So good night, everyone.
And good morning.
Good day. Yes.
Good day.
Thank you so much, everybody.
Thank you.
Thank you.